Okay, let's unpack this. Our bodies are incredible machines, constantly repairing themselves, often without us giving it a second thought. One of the most impressive feats, healing a broken bone. It's this uh, intricate, natural process happening under the surface all the time.
Absolutely. It's a remarkably complex interplay of, well, biology and mechanics.
And sometimes, for various reasons, that natural process just isn't enough. The break might be too severe or, something interferes with healing.
Right.
And that's when we need to turn to surgical interventions, implants, grafts, and other clever ways to help things along.
Hmm.
We've got this fascinating stack of source material here. Articles, research, notes you've shared diving deep into bone mechanics, how they heal, the forces at play, what happens when things don't go to plan, and the whole world of surgical fixes.
Yeah, this deep dive, based on the sources you've given us, this is our mission today. We're going to explore what makes bone such a unique material, walk step by step through the body's own healing process, get into the science behind the materials and implants surgeons use, understand why even the best implants can sometimes fail, and tackle that really challenging problem of fractures that just, that just don't heal.
It's more than just memorizing medical terms, isn't it? This is about understanding the fundamental engineering and biology that allows us to move and the sophisticated ways science steps in when that system breaks down. It's where material science meets the messy, amazing process of biological healing.
Exactly. By the end of this, you'll have a much clearer picture of not just the bone heals or that an implant is used, but why it happens the way it does and what needs to go right or, what can go wrong for successful recovery.
So let's jump in, starting with the foundation. What makes bone such a remarkable material in the first place?
Well, think of bone like a natural composite material, a bit like reinforced concrete, in concept anyway. It's primarily made of two main components. A mineral phase, mostly calcium and phosphate, which gives it hardness and stiffness, and a collagen matrix, which is a protein framework that gives it flexibility and toughness. Together, these two parts are far stronger and more resilient than either would be on its own.
Stronger together, nature figured that out long ago. And it's not uniform in how it behaves depending on how you push or pull on it, right? It's what's called anisotropic.
That's exactly right. Anisotropic means its mechanical properties like stiffness and strength are different depending on the direction the force is applied. It's also viscoelastic.
Viscoelastic?
Yeah, which means its response isn't just about the amount of force, but also how quickly that force is applied. The faster you load it, the stiffer it seems to be.
Okay, so this composite directional material handles different types of forces in specific ways. How does this structure influence how bone actually breaks?
The adult cortical bone, that's the dense outer layer. It's strongest when you compress it, weaker when you pull it in tension, and weakest when you apply shear, which is like a sliding force.
Weakest in shear.
Yeah. Now, most fractures actually happen from a combination of these forces. But understanding the pure modes helps explain the fracture patterns we see.
Can you give us some examples based on these different stresses, like what happens under tension?
Sure. If you apply pure tension, bone tends to fail by the tiny structural units inside it, called osteons, sort of pulling out, or the bonds between them, the cement lines, breaking apart.
Ah.
This typically results in a transverse fracture, a break, straight across the bone. You often see this pattern in areas with more cancellous bone.
The spongier bone.
Exactly. The spongier bone found at the ends of long bones or smaller bones like the heel or parts of the foot.
So even under tension, that spongier bone seems prone to those straight breaks. What about compression?
Pure compression fractures are actually less common, especially in the shafts of long bones. But when bone is compressed to failure, the break tends to occur from oblique cracking within the osteons themselves.
Oblique crack.
Yeah, resulting in an oblique fracture, usually angled around, say, 30 degrees. These are more often seen in the wider ends of bones, the metaphyses, where that cancellous bone gets compressed.
What about bending? That seems like a really common way of bones break, like falling on your arm.
Oh, absolutely. Bending is fascinating because it's a combination. When you bend a bone, one side is put under tension and the opposite side is put under compression.
Right, tension and compression working together.
Exactly. And since adult cortical bone is weaker in tension,
Which you just mentioned.
right, the fracture typically starts on that tension side. Once the crack begins there, it progresses transversely, straight across the bone. A classic example is a boot top fracture of the tibia, where the rigid ski boot creates that bending moment.
I can picture that.
Interestingly, though, in children whose bone is more ductile or flexible because it has more collagen.
More bendy.
Yeah, more bendy. A bending force might cause the bone to buckle or bend without a complete snap. That leads to things like green stick or Torres's fractures.
Like bending a green stick, it doesn't snap cleanly.
Okay.
And shear, you said that was the weakest link.
Shear loading causes a sliding or angular deformation within the material. And even when you're applying tension or compression, there's often a shear component involved. Pure shear failures often happen in those cancellous bone areas that experience this kind of sliding, like the tibial plateau at the top of the shin bone.
The knee.
Or the femoral condyles in the knee, yeah. Especially from forces like twisting while you're bearing weight.
So the material properties are key, obviously, but the shape of the bone must also significantly impact its strength and how it handles these loads.
Absolutely. Geometry is critical. It's like engineering efficiency built in. For simple tension or compression, the stiffness and the load it takes to fail are directly related to the bone's cross-sectional area. Bigger area, stronger bone. Pretty straightforward.
Makes sense.
But for bending and twisting, or torsion, it's the distribution of the bone tissue that matters most.
Distribution. You mean like if the material is spread out or packed in the middle?
Exactly like that. For bending stiffness, it's related to something engineers call the area moment of inertia. Bones naturally distribute most of their material further away from the central axis, like a hollow tube.
Okay.
Think about it. A hollow tube is much harder to bend than a solid rod made of the same amount of material, right? Because the material is further from the bending axis. Bones use this principle to be stiff in bending without being excessively heavy.
Clever design.
And for twisting, it's a similar concept called the polar moment of inertia, which also favors tissue distributed away from the center.
Nature's lightweight, high-strength engineering at work. What about features like holes? You know, where blood vessels enter the bone. Do those affect strength?
They definitely do. Any discontinuity, like a hole or even just a scratch on the surface, can act as a stress riser.
Stress riser, meaning stress builds up there.
Exactly. The stress from loading gets concentrated around that point, making it more likely to fail right there. And sharp corners are worse than smooth curves for this effect. Our sources point out that a hole diameter, just 10% of the bone's diameter, can reduce bending strength by like 20%.
Wow, that much.
Yeah, it really highlights how sensitive bone is to local imperfections, especially under bending or torsion.
Fascinating how the microscopic structure, microscopic shape, and even small features all play a role. But when a bone does break, despite all this, that's when the body's incredible built-in healing process kicks off.
And it starts immediately, right away, with the formation of a hematoma, basically, a large blood clot right at the fracture site. This initial clot is crucial because it contains cells and, importantly, signaling molecules needed for the next steps.
So the body seals the area and sends out an SOS signal. Kind of.
Precisely. Within, say, 24 to 72 hours, the inflammatory response is in full swing. Immune cells like macrophages show up to clean up debris and damaged tissue. But maybe more importantly, the injured cells and platelets release this complex mix of signaling molecules. Think of them as a chemical command center.
Okay.
These include cytokines and powerful growth factors like bone morphogenetic proteins, BMPs, TGF-E, PDGF, FGFs, and others. Lots of acronyms, but they're all chemical messengers.
And what do these signals actually do?
They are absolutely essential for recruiting and directing the repair cells. These are undifferentiated mesenchymal cells and osteoprogenitor cells to the fracture site. BMPs are particularly significant because they are osteoinductive.
Osteoinductive means they induce bone growth.
Yes, they can actually tell these basic mesenchymal cells to differentiate specifically into osteoblasts, the cells that actually build new bone.
Okay, so the site is cleaned up, the right cells are called in, and they're getting instructions. What's the next big phase in the repair?
This is the reparative phase. It starts within about 2 weeks and can continue for several months. The arriving mesenchymal cells differentiate based on the local conditions, the signals they're getting. And crucially, new blood vessels start growing into the area that's neovascularization, which is vital for delivering oxygen, nutrients, and more repair cells.
And this is where we start seeing the callus, that bulge around the break.
Exactly. First, especially in areas where the fixation isn't perfectly rigid, fibroblasts and chondroblasts lay down cartilage and fibrous tissue within that hematoma, forming what's called the soft callus.
A temporary scaffold.
Kind of, yeah. Then, through a process called endochondral ossification, which is actually similar to how bone forms when we're developing.
Right.
This soft callus is gradually converted into woven bone, creating the hard callus.
Yeah.
At the same time, New bone is formed directly from the outer layer of the bone, the periosteum, through a different process called intramembranous ossification. This adds significantly to the callus volume, especially around the fracture circumference.
So a cartilage scaffold is built and then replaced by bone, while bone is also built directly from the surface layer. Does how stable the fracture is affect how much callus forms? I imagine it must.
Absolutely. This is a really key insight from the sources. There's an inverse relationship between the rigidity of the fixation and the amount of visible callus.
Meaning more rigid fixation, less callus.
Exactly. If you have very rigid internal fixation, like, say, compression plates that hold the bone ends tightly together, the body tends to heal the fracture directly across the gap with little or no visible external callus. This is sometimes called primary bone healing.
Okay.
But if the fixation is less rigid, like a cast or maybe a flexible nail inside the bone, you get much more robust callus formation. The body relies on that soft and hard callus bridge to stabilize the fracture. That's secondary bone healing.
That makes sense. The body adapts its strategy based on how much stability is provided externally. And after the hard callus forms, the bone isn't finished healing, is it?
No, not at all. Then comes the longest phase, remodeling. This can take months, even years. The initial woven bone of the hard callus is relatively disorganized, kind of weak structurally.
Like a quick patch job.
Sort of, yeah. In the remodeling phase, it's gradually replaced by stronger, more organized lamellar bone. The callus is refined, gets smaller, and the bone reshapes itself, trying to get back to its original form and strength.
And this reshaping is influenced by how the bone is used, right? That Wolff's law thing, form follows function.
Precisely. The bone adapts to the mechanical loads it experiences.
Mm-hmm.
Areas under higher stress become denser. Areas under lower stress might become less dense.
Mm.
In cortical bone, this remodeling happens via these structures called cutting cones.
Cutting cones?
Yeah, they're like little tunneling machines. Osteoclasts carve out temporary tunnels, and then osteoblasts follow behind, filling them in with new lamellar bone. In cancellous bone, remodeling happens more on the surface of the struts, thickening or thinning them as needed. Over time, even the medullary canal, the hollow center, gets repopulated and reformed.
It's an incredible multi-year process of rebuilding and fine-tuning. And this constant breaking down and rebuilding happens even in uninjured bone, doesn't it? Through the bone remodeling unit, the BMU.
Yes, exactly. The BMU, or bone remodeling unit, is the cellular machinery responsible for this constant turnover, even in healthy bone. It's a temporary team of cells that carries out a specific sequence, identifying old or damaged bone, resorbing it with osteoclasts.
The breakdown crew?
Right. Then recruiting osteoblasts, the builders to the site, and then they lay down new bone matrix, called osteoid, which then mineralizes into hard bone. This unit is active during normal remodeling and plays a big role in those later stages of fracture healing, too.
So the body has this sophisticated repair system, but sometimes, despite all these mechanisms, healing slows down or just stops altogether.
That's the challenging part, yeah.
Yeah.
Many factors can influence whether bone healing proceeds normally. We can kind of group them into systemic factors, things affecting your body as a whole,
Okay.
and local factors, things specific to the fracture site itself.
What are some key systemic factors that can slow things down?
Well, age, unfortunately, is a big one. Healing generally tends to be slower and maybe less robust as we get older. Nutritional status is critical. Bone needs protein, calcium, vitamin D, and other nutrients to rebuild.
Makes sense.
Hormones play a role too. For instance, long-term use of corticosteroids like cortisone can significantly decrease callus formation, while growth hormone and androgens tend to increase it. General health conditions, your functional activity level, nerve function, because that affects blood flow and muscle activity, and certain medications.
Like painkillers.
Yeah, particularly NSAIDs, non-steroidal anti-inflammatory drugs, especially if used for a long time, can potentially negatively impact healing.
And at the local level, right there at the break, what can go wrong?
The severity of the original trauma is huge. How much damage was done to the surrounding soft tissue and, critically, the blood vessels. Poor blood supply is a major impediment to healing because it limits the delivery of oxygen, nutrients, and those crucial repair cells.
Got it. Blood supply is key.
Absolutely. Other local factors include bone loss at the fracture site, pre-existing pathological conditions in the bone itself, the specific type of bone. Broken some bones, like the scaphoid in the wrist or the lower part of the tibia, just have an inherently poor blood supply or experience difficult mechanical forces. Insufficient or even excessive immobilization, and critically, infection at the fracture site. Infection is a huge disruptor.
You mentioned blood supply is vital. How does a surgical procedure like reaming the intramedullary canal, basically drilling out the inside of the bone before putting in an IM nail affect it? Doesn't that damage the internal supply?
That's a really interesting point, and it's counterintuitive sometimes. Normally, in mature bone, blood flow in the cortex, that dense outer part, is mainly centrifugal. It flows from the inside lining, the endosteum, outwards towards the outer layer, the periosteum.
Inside out.
Right. Reaming does temporarily disrupt that endosteal blood supply. However, the body compensates pretty remarkably by significantly increasing blood flow from the periosteum inwards, essentially reversing the usual flow pattern. And within about 6 weeks or so, the cortical blood flow generally recovers. Plus, the reaming process itself brings in cells and growth factors from the marrow that can actually promote healing. So while there's an initial disruption, the overall effect, particularly with weaned nails, can often be positive, leading to quicker union compared to unreamed nails, partly by stimulating that increased periosteal blood flow.
So even a temporary disruption can trigger a beneficial response.
Fascinating. Now, when natural healing is slow or fails, or the fracture pattern just needs mechanical support, that's when surgical implants become necessary.
Right. These are biomaterials, non-viable materials, not living tissue, but designed to interact safely and effectively with biological systems. We talk about biocompatibility.
Meaning it doesn't cause a bad reaction.
Exactly. The material performs its function without causing an unacceptable local or systemic reaction from the body. And we also talk about bioinertness, which describes materials that cause minimal host response, almost like they're ignored by the body.
What kinds of materials were typically used for bone implants? The most common are metals, like stainless steel and various titanium alloys. But we also use polymers, like polyethylene, especially in joint replacements, ceramics, and sometimes composites. Each has different mechanical properties: stiffness, hardness, ductility, corrosion resistance, and so on.
How do stainless steel and titanium compare?
Well, stainless steel is typically cheaper and generally more ductile, meaning it can bend more before breaking. Titanium alloys are generally more inert, meaning they tend to cause less biological reaction, and importantly, they're less stiff than stainless steel.
Is less stiffness always a good thing for an implant?
It often can be, especially when you're trying to work alongside living bone. Remember, bone itself is a dynamic composite material designed to adapt to load through remodeling. You put a very, very stiff implant next to bone.
Like a stiff steel plate.
Yeah, exactly. The implant can take on too much of the mechanical stress, essentially shielding the bone from the load it needs to sense to remodel and stay strong. This is called stress shielding.
And that can make the bone weaker.
It can lead to bone resorption, basically bone loss, right around the implant because the bone isn't getting its normal mechanical stimulation. Titanium alloys are less stiff than stainless steel, closer to the stiffness or modulus of elasticity of bone itself. This helps reduce that stress shielding effect, allowing the bone to share more of the load.
That makes a lot of sense. You want the implant to support, but not completely take over the bone's job. Let's talk about the specific types of implants. Screws seem pretty fundamental, right?
Absolutely. Screws are used everywhere to hold bone fragments together, to attach plates to bone. They have different parts: a head, a shaft, threads, and a tip. The design of the threads is really crucial.
How so?
Well, cortical screws, for the dense cortical bone, have fine, closely spaced threads optimized for gripping that hard material. Cancellous screws for the spongier cancellous bone have much coarser, wider pitched threads designed to get a good purchase in that less dense bone. The shape of the thread, like a buttress profile, can also be designed to maximize compressive forces when tightened.
And different tips for different jobs.
Yep. The tip determines how the screw enters the bone. Blunt self-tapping tips have cutting flutes that cut their own thread path and clear out bone chips as they go in. Blunt, non-self-tapping tips require you to drill a pilot hole and then tap threads into it first.
Like preparing a hole for a machine screw.
Exactly. Then there are corkscrew tips designed specifically for cancellous bone to provide compression, and trocar tips that sort of displace bone as they advance rather than cutting. Careful drilling technique is important before insertion to avoid overheating and damaging the bone, and tapping the hole before inserting a non-self-tapping screw is generally considered good practice.
Got it. How about plates? They seem like the other main workhorse.
Plates are essentially like internal splints or bridges that are fixed to the bone surface with screws. They're primarily load-bearing implants, meaning they often carry a significant portion of the mechanical load across the fracture site, especially initially.
And different plates do different things.
Yes, different plate designs serve different mechanical functions. Compression plates are designed to actively squeeze bone fragments together to promote primary healing. Neutralization plates protect screws and the bone itself from bending and twisting forces when maybe lag screws are used for compression. Buttress plates act like a wall to prevent bone fragments from collapsing under compressive load, often used near joints.
Okay.
Bridging plates are used to span large gaps in the bone where there's significant bone loss or comminution, protecting the area while healing occurs underneath. And tension band plates are clever. They're placed on the tension side of a fracture that's subject to bending loads, and they work by converting those distracting tensile forces into stabilizing compression forces across the fracture site.
So plates are on the surface, often taking a lot of the load. How do they compare to intramedullary nails, those rods inserted down the hollow center of the bone? That seems like a totally different approach.
It is a different philosophy, and that's a key comparison often highlighted in the sources. IM nails, unlike most plate applications, are generally considered load-sharing devices.
Load sharing.
Meaning the nail takes some of the load, but the bone itself is also expected to share the burden right from the start, which can be good for stimulating healing.
How are they put in?
IM nails are typically inserted through a smaller incision, often distant from the fracture site itself, and then passed down the medullary canal. This often preserves the soft tissue envelope and the crucial perioscale blood supply around the fracture much better than plates, which sit right on the bone surface and require more stripping of tissue, potentially disrupting that supply.
So less invasive, preserves blood supply. What fractures are they best for?
They are excellent for shaft fractures of long bones, think the femur and the tibia. They often allow some controlled micromotion at the fracture site, which is thought to encourage that robust callus formation and secondary bone healing we talked about.
Interesting. Where do they tend to fail if things go wrong?
Failure often occurs at the interlocking screws, or cross bolts, that are used to lock the nail rotationally and prevent shortening. An interesting design feature mentioned in the sources is that many IM nails have a slot down the side. This slot significantly reduces the nail's torsional stiffness.
Makes it less stiff against twisting.
Exactly. It allows a little bit more rotational flexibility at the fracture site, which, again, is thought by some to stimulate callus healing.
So summarizing, IM nails, load sharing, preserve tissue, and blood supply, promote callus healing via micromotion, good for long bone shafts, and plates again.
Plates are generally load-bearing, sit on the surface, potentially disrupting perioscale supply, often require more extensive surgical dissection to apply accurately, lead to more rigid fixation, and thus often result in primary healing with little or no visible callus. They tend to fail at the plate itself, through bending or fatigue fracture. Plates are generally preferred for fractures near or involving joints, intra-articular or juxta-articular fractures, or for very complex fracture patterns where an IM nail just isn't suitable mechanically.
Okay, that clarifies the trade-offs. What about external fixators, the frames on the outside?
External fixators involve drilling pins or wires into the bone fragments above and below the fracture, and these are then connected to a rigid frame outside the body.
What are the pros and cons there?
The big advantages are that they can be applied relatively quickly, especially in trauma situations. They completely preserve the soft tissues and blood supply around the fracture site itself, and they allow easy access to the wound if it's an open fracture that needs care. They're also adjustable after application.
But the downsides?
The main disadvantages include the risk of infection, where the pins or wires enter the skin pin. Pin tract infection is a common issue. There can also be potential problems with achieving and maintaining perfect fracture alignment, or malunion, if not applied carefully. And they can be quite cumbersome for the patient, requiring careful cleaning and management, impacting daily life.
What types are there?
They range from simple rod fixators connecting a few pins to complex circular frames like the Elizarov apparatus, which allow for controlled distraction or compression, to very sophisticated computer-assisted spatial frames that allow precise multiplanar corrections.
And after everything is healed, sometimes these implants, nails, plates, screws need to come out.
Yes, implant removal is often considered, typically after 12 to 18 months, especially in younger active individuals, or if the implant is causing specific symptoms like pain or irritation.
Is it routine, or are there risks?
It's definitely not without risk. There's a non-trivial risk of refracture after the implant is taken out, particularly with plates removed from the forearm, for example. The bone might not have fully regained its strength due to that stress shielding effect we discussed. There can also be risks of nerve injury or other complications during the removal surgery itself. It's a decision that needs careful consideration.
So while implants are crucial for stability, they introduce their own set of potential problems. Let's talk about when implants themselves fail. What does that mean exactly?
Implant failure simply means the implant doesn't perform the job it was intended to do, whether that's providing stability, bearing load, or maintaining alignment until the bone heals. This can happen due to issues with the material itself, the implant design, or how it was applied surgically.
What are the main ways an implant can fail? Corrosion sounds like a big one for metal in the body.
It is. Corrosion is the deterioration of the metal through electrochemical action within the body's fluid environment. It's essentially like a tiny battery effect happening right on the implant surface.
A battery inside you, that sounds not good.
Well, the body fluids act as the electrolyte. Fortunately, most modern implants are made of materials that form a very thin, stable protective oxide layer on their surface through a process called passivation. This layer helps resist general corrosion.
Passivation, like a shield.
Exactly. But certain conditions can break down this protective layer. You can get galvanic corrosion if two different types of metals are in contact within the body.
Like mixing steel screws with a titanium plate.
Precisely. That's generally avoided. Then there's fretting corrosion caused by surface damage due to microscopic motion between implant components, like a plate and a screw head. Crevice corrosion can happen in tight, low-oxygen spaces, again, like under screw heads or plate interfaces. Pitting corrosion is localized breakdown, maybe from surface abrasion. And stress corrosion is where a crack in the metal is accelerated by the corrosive environment.
How do surgeons minimize this?
By using highly corrosion-resistant materials like titanium alloys or specific stainless steels, by avoiding mixing different metal alloys in the same implant construct whenever possible, and by using good surgical technique to handle implants carefully and ensure stable fixation, which reduces micromotion.
Okay, so corrosion is like a chemical attack. What about pure mechanical breakdown? You mentioned fatigue earlier with bone. Does it happen to implants too?
Absolutely. Fatigue is a major mechanical failure mode for implants, just like it is for bone. This is progressive structural damage that occurs from repeated cycles of stress, even if each individual stress cycle is well below the material's ultimate tensile strength, the force needed to break it in one go.
So repeated loading wears it out.
Essentially, yes. Over time, microscopic cracks form and slowly grow with each loading cycle until the remaining material can't take the load anymore, and the implant suddenly fails, it fractures.
And where do these fatigue cracks usually start?
Almost always at stress risers. Just like in bone, these are points where stress gets concentrated due to geometric irregularities, maybe a scratch from handling, a hole for a screw, a sharp corner in the design, or a sudden change in the implant's shape or thickness.
Can't they design implants to last forever?
Well, many materials have a theoretical endurance limit, or fatigue limit, a stress level below which fatigue supposedly shouldn't occur, no matter how many cycles. But our sources emphasize that for orthopedic implants in the human body, relying on this concept is unreliable, even dangerous.
Why is that?
Because the body is a corrosive environment, which accelerates fatigue. The stresses on the implant are complex, variable, and often unpredictable. And the implant surface can be inadvertently damaged during insertion, creating those stress risers. So implants basically have a finite fatigue life, especially if the bone isn't healing properly and continues to load the implant heavily, cycle after cycle.
So preventing fatigue failure isn't just about the material, it's about the design and, crucially, getting the bone to heal.
Exactly. Good implant design aims to minimize stress risers. Surface treatments can improve fatigue resistance, but most importantly, achieving timely bone union, which allows the bone to start sharing the load with the implant, is the best way to reduce the cyclic stresses on the implant and significantly extend its fatigue life. An implant supporting a non-healing fracture is living on borrowed time, mechanically speaking.
Makes sense. What about other mechanical failures? You mentioned buckling or wear.
Buckling is a sudden instability failure under compression, typically seen in thin-walled structures like tubes. While some aspects of IM nail design might theoretically need to consider this, bone itself is generally considered thick-walled, so it's less common than fatigue. Wear, however, is a big issue.
Wear, like parts rubbing together.
Yes, mechanical deterioration of surfaces that are in contact and moving against each other due to friction. The main types are abrasive wear, where a harder surface scratches a softer one, and adhesive wear, where tiny bits of material transfer between surfaces that are pressed together and slide.
Where is where most problematic?
It's particularly problematic in total joint replacements, hips and knees especially, where particles, particularly the tiny plastic particles from polyethylene components, can trigger a biological inflammatory response. This inflammation can lead to osteolysis.
Bone breakdown.
It's exactly. bone breakdown right around the implant. This loosens the implant's fixation to the bone, causing pain and ultimately leading to implant failure and the need for revision surgery. Managing wear is a huge focus in joint replacement design and material science.
That wear particle issue leading to bone loss sounds like a major long-term challenge for joint implants.
It absolutely is. And speaking of serious complications, perhaps one of the most challenging causes of implant failure is septic loosening, which is basically loosening caused by infection at the implant site.
Infection again?
Yes. There's a key concept here from the sources called the race for surface. Think about it. When an implant is inserted, its surface is immediately exposed to the body's own cells and potentially any bacteria present from the skin or the surgical environment.
And they both want to stick to it.
Exactly. Both the body's cells, which we want to integrate with the implant, and any bacteria are trying to colonize that implant surface. It's a race.
And if the bacteria win the race?
If bacteria colonize the surface first, they can very quickly form a protective matrix around themselves called a glycocalyx, essentially, a slimy, sticky biofilm.
Biofilm, I've heard of that.
It's incredibly effective at shielding the bacteria from the body's immune cells, like white blood cells. And it also acts as a barrier that makes antibiotics hundreds, even thousands of times less effective against the bacteria hiding inside.
Wow, so they're protected.
They're protected. They multiply, cause chronic low-grade infection and inflammation, and this ultimately leads to the bone around the implant being resorbed or eaten away, causing the implant to become loose and fail. Winning that race for surface by preventing bacterial colonization in the first place through sterile technique and sometimes antibiotic coatings is absolutely critical for implant success.
The race for surface, that's a really vivid way to understand the challenge. So when natural healing isn't happening, maybe complicated by some of these implant issues, we need direct ways to stimulate bone formation. This is where bone grafting comes in, right?
Exactly. Bone grafting involves using some kind of material to replace missing bone, add structural volume, or actively stimulate the bone healing process where it's stalled. Grafts are usually classified by where they come from.
Okay, what are the types?
There's autograft, which is bone taken from the patient's own body, usually from the iliac crest, the hip bone. There's allograft, which is bone harvested from another human donor, typically a cadaver, which is then processed and sterilized. And there's xenograft, which is bone derived from a different species, like bovine bone, again heavily processed.
When would a surgeon decide a bone graft is needed?
Common reasons or indications include providing structural support for large bone defects, maybe after trauma or tumor removal, bridging gaps in a bone that are simply too large for the body to heal across on its own, augmenting or kickstarting healing in cases of non-union where healing is stopped, or filling voids left after cleaning out infected bone.
And how do these grafts actually work? You mentioned stimulating healing. What are the mechanisms?
Grafts generally work through three main biological mechanisms. You can think of it like rebuilding a wall that's partly collapsed.
Okay.
First is osteogenesis. This means the graft material itself contains living bone-forming cells that can actively produce new bone right away. Autograft, because it's fetched from the patient, is the only type with significant osteogenic potential.
So bringing the actual builders to the site.
Exactly. Second is osteoinduction. This means the graft material contains or releases signaling molecules like those BMPs we talked about earlier that recruit the patient's own stem cells from the surrounding tissue and chemically tell them to differentiate into bone-forming osteoblasts.
Like putting out a signal flare to call in local builders?
That's a great analogy.
Yep.
And third is osteoconduction. This means the graft material provides a physical scaffold or framework, a structure that the patient's own new blood vessels and bone cells can grow across and into. It doesn't stimulate new bone directly, but it provides the necessary architecture.
Like providing the scaffolding for the builders to work on.
Precisely. So osteogenesis cells, osteoinduction signals, and osteoconduction scaffold.
So autograft, the patient's own bone, is like bringing in the builders, the signal flares, and the scaffolding. Sounds like the best option.
It often is. Autogenous cancellous bone, that spongy bone typically taken from the iliac crest, is frequently considered the gold standard because it has the highest potential in all three mechanisms. It provides live cells, osteogenesis, growth factors, osteoinduction, and a porous structure, osteoconduction.
But there must be downsides, like needing a second surgery site.
Exactly. Downsides include the need for that separate ARVIS site, which has its own risks like pain, bleeding, infection, nerve injury, and there's only a limited amount you can take. Cortical bone grafts, the denser bone, are better for structural support, but are much less osteogenic and osteoinductive. Allografts and xenografts avoid the harvest site morbidity but lack living cells and have variable osteoinductive potential. Plus, there's a small theoretical risk of disease transmission or immune response, although processing minimizes this. Many engineered materials or ceramics are primarily just osteoconductive scaffolds, and BMPs used alone are purely osteoinductive signal flares.
So different grafts have different strengths. And like natural healing, these grafts have to integrate, right? They go through stages.
Yes, absolutely. A graft has to become part of the host bone. After implantation, there's initial hemorrhage and inflammation around it. Then, crucially, revascularization occurs as new blood vessels from the host grow into the graft material.
Bringing it back to life, essentially.
In a way. Then comes this process called creeping substitution. It's a slow process where the host's own bone cells gradually lay down new bone on the surface of the graft matrix, while other cells, osteoclasts, slowly resorb the old, dead graft material. It's a coordinated replacement over time.
What about engineered materials? Are they starting to replace traditional bone grafts?
They're definitely playing an increasing role. Non-viable engineered materials like certain polymers, polylactic acid, PLA, polyglycolic acid, PGA, and various ceramics like hydroxyapatite, calcium sulfate, or tricalcium phosphate are used as bone graft substitutes or extenders.
What's their main advantage?
They avoid the need for harvesting autograft or using allograft. They are primarily osteoconductive, providing that scaffold. Some are designed to degrade resorbed by the body over time as new bone grows in to replace them. They can also be manufactured with controlled porosity and sometimes combined with growth factors like BMPs to add osteoinductive properties. They offer alternatives, though autograft still remains the gold standard for biological activity.
We focused heavily on bone, but cartilage, like in joints, is notoriously difficult to heal. Are there similar interventions being developed for cartilage damage?
Cartilage healing is much more challenging, mainly because articular cartilage, the smooth stuff on joint surfaces, has a very limited blood supply and very few cells in adulthood. It just doesn't have the same intrinsic repair capacity as bone.
So no easy fix.
No, there's no single consistently reliable way to regenerate damaged cartilage back to its original state. Research is exploring lots of avenues, using growth factors, various cell therapies like implanting cultured chondrocytes, and different types of artificial matrices or scaffolds, similar in principle to bone grafting strategies, but it's a much harder biological problem to solve. Growth factors like IGF and even BMPs are being studied for their potential to influence chondrocytes, the cartilage cells, but clinical applications are still evolving.
I've definitely heard of people getting injections like hyaluronan for knee osteoarthritis. Is that considered a cartilage intervention? How does that fit in?
That's a good question. Intra-articular hyaluronan injections, sometimes called viscosupplementation, are used for symptomatic osteoarthritis. The idea is to inject a substance similar to natural joint fluid to provide lubrication and potentially some anti-inflammatory effects within the joint.
Does it rebuild cartilage?
No. It's important to understand, based on our sources, that it is not a cartilage regenerating treatment. It doesn't repair the underlying damage. It's primarily aimed at reducing pain and improving function.
When is it considered appropriate then?
The sources clarify the typical indications. It's for patients with documented osteoarthritis, meaning they have radiographic evidence like X-rays showing joint space narrowing or osteophytes, and they have significant pain that affects their function. Usually it's considered after other conservative treatments like physical therapy, weight loss, activity modification, and NSAIDs have failed to provide adequate relief, and often after a trial of corticosteroid injection has also failed or provided only temporary benefit.
So it's further down the treatment ladder?
Generally, yes. It's considered inappropriate for inflammatory joint diseases like rheumatoid arthritis, or if there's any sign of joint infection. If an initial course of injections provides good relief, the sources suggest repeated courses are appropriate if that relief lasts for at least 6 months. So it's really about managing symptoms in specific cases, not a cure or a way to regrow cartilage.
Okay, that makes sense. A symptomatic treatment, not a regenerative one. Now, shifting gears a bit, beyond grafts and materials, can we actually use electricity to influence bone healing? That sounds a bit sci-fi.
It does, but it's based on real biology. Bone is actually unique in that it naturally exhibits electrical properties when bone is mechanically loaded or stressed.
Like during walking or exercise?
Exactly. It generates tiny electrical potentials. There's the piezoelectric effect, which comes from stress on the mineral crystals themselves. There are streaming potentials generated by the flow of fluid through the tiny channels within the bone matrix. And there are also transmembrane potentials related to the activity of the bone cells. These natural electrical signals are thought to play a role in normal bone remodeling, part of how bone senses and responds to load.
So the body uses electricity internally, and we can tap into that. Can we use artificial electrical or electromagnetic fields to enhance healing when it's not happening?
That's the idea, yes. Research has shown that applying low-level electrical currents or pulsed electromagnetic fields, PEMF, can influence the behavior of bone cells, specifically stimulating osteogenesis, new bone formation.
How does that work?
The exact mechanisms are complex and still being studied, but these fields appear to modify cell signaling pathways, potentially mimicking some of those natural electrical cues. There's even a fascinating dose-response relationship noted in the sources regarding direct electrical current. Too little current, say less than 5 microamps, seems to have little effect. A certain range, roughly 5 to 20 microamps, appears to promote bone formation, but too much current, over 20 microamps, can actually cause tissue damage or necrosis.
So getting the dose right is critical.
Absolutely. And importantly, for direct current stimulation, the cathode, the negative electrode, must be positioned right at the fracture site or non-union site to effectively stimulate bone formation. PEMF devices work slightly differently, inducing small electrical currents within the tissue electromagnetically, again influencing cell behavior.
How are these treatments actually applied to a patient?
There are different methods, broadly categorized as invasive, semi-invasive, and non-invasive. Invasive methods involve surgically implanting electrodes, and sometimes the power source directly at the fracture site. Semi-invasive methods use pins or wires inserted through the skin into the bone near the fracture, which are then connected to an external power source.
Sound like external fixation pins.
Similar concept, yeah. And non-invasive methods use external coils or pads placed on the skin over the fracture site. These generate PEMFs, or deliver current capacitively or inductively through the skin without breaking it.
What are the pros and cons?
Well, invasive and semi-invasive methods deliver the electrical stimulus more directly to the target tissue, but they carry the risks associated with surgery and implants, namely infection. Non-invasive methods avoid the surgical risks, but may require the patient to use the device for many hours per day, raising compliance issues, and the energy delivery to the actual fracture site might be less precise or efficient. Some systems also require the patient to be non-weight-bearing during treatment, which can be a significant drawback.
These interventions, like electrical stimulation and complex grafting, seem particularly relevant when we face the most difficult challenge in fracture care: non-union, when the bone just won't heal.
Exactly. Non-union is formally defined as the arrest of the fracture healing process. It means bony union won't occur without some kind of intervention. Instead of solid bone bridging the gap, you find persistent fibrous tissue or sometimes cartilage.
And what's pseudoarthrosis? I've heard that term too.
Pseudoarthrosis, which literally means false joint, is generally considered the final mature stage of a non-union. It's characterized by the formation of a fluid-filled cavity between the bone ends, often lined by a synovial-like membrane, almost like the body has given up on healing and tried to create a functional though unwanted joint at the fracture site.
Wow. What causes a fracture to go down this path and become a non-union in the first place?
The causes often boil down to either biological problems, mechanical problems, or, very commonly, a combination of both. General systemic factors that we mentioned earlier, things like advanced age, poor nutrition, smoking, diabetes, certain medications, chronic illness, can certainly predispose someone to healing problems.
Okay, the patient's overall health.
Right. But local factors at the fracture site are often more direct culprits. Biological issues include severe soft tissue damage around the fracture compromising blood supply, poor vascularity of the bone fragments themselves, vascular necrosis, significant bone loss creating a large gap, underlying pathological conditions in the bone like a tumor, or, very importantly, infection.
And mechanical issues.
Mechanical problems are also critical. This includes excessive motion or instability at the fracture site. The fixation wasn't good enough. Or, conversely, sometimes too much rigidity with a very large gap can hinder healing. Also, having soft tissue trapped between the bone ends, interposition, prevents them from uniting, or continuously distracting the fracture fragments can also lead to non-union.
So if the biology isn't robust enough, or the mechanics are all wrong, or both, it can lead to non-union. And pseudoarthrosis is like the body trying to make the best of a bad situation by creating that false joint.
That's a pretty good way to look at it. Pseudoarthrosis tends to progress through stages. Initially, you have the established non-union with fibrous or cartilaginous tissue in the gap. Then the bone ends also become dense and rounded off, sclerotic. A fluid-filled cavity can form between them, followed by the development of that synovial-like lining, and sometimes even articular cartilage-like tissue on the bone ends, essentially mimicking a joint structure. You can also sometimes get excessive bone overgrowth or hypertrophy around this false joint.
How do clinicians categorize non-unions? Does it help guide treatment?
Yes, classification helps understand the underlying biology and plan treatment. A common and useful classification, like the one by Weber and Seck, divides non-unions based on their biological activity, which is often reflected in their X-ray appearance.
What are the main types?
They distinguish between hypertrophic or hypervascular non-unions, which show abundant callus formation. They look like an elephant foot or horse hoof on X-ray.
So the body's trying to heal.
Exactly. Biologically active, lots of blood supply, lots of callus, but they fail to bridge the gap, usually because of persistent instability or excessive motion. The biology is there, but the mechanics are wrong.
Okay, and the other type?
The other main type is atrophic or avascular non-unions. These show minimal or completely absent callus formation. The bone ends often look thin, tapered, or resorbed on X-ray. Here, the primary problem is poor biology, often poor blood supply, maybe significant bone loss or severe scarring. The mechanics might be stable, but the biological engine for healing has stalled.
Hypertrophic, good biology, bad mechanics versus trophic, bad biology. That makes sense.
Right. Non-unions can also be classified by time, like delayed union versus established non-union, the specific location in the bone, and very importantly, whether infection is present or absent. Infected non-union is a whole separate challenge.
How is a non-union definitively diagnosed?
It usually starts with the clinical picture.
Yeah.
The patient has persistent pain, maybe swelling, tenderness, and often abnormal motion or instability at the fracture site long after you'd expect it to have healed clinically and radiographically.
So history and physical exam first.
Yes. Then imaging is key. Serial X-rays are fundamental, showing the lack of progressive bony bridging across the fracture gap over time, and often revealing those characteristic bone end appearances, sclerotic and hypertrophic, or tapered and atrophic.
What about other imaging?
CT scans are often very helpful. They provide much better detail of the bone ends, the size of the gap, any malalignment, the amount of bone loss, and can help rule out subtle union that might be missed on plain X-rays. MRI might be used occasionally to assess soft tissue interposition or to look for signs of infection or vascular necrosis. Sometimes nuclear medicine bone scans or specialized blood flow studies might be used to assess the vascularity and biological activity at the non-union site, helping distinguish hypertrophic from atrophic types.
Given the multiple potential causes, mechanical, biological, infection, what's the guiding principle for treating a non-union successfully?
The fundamental principle, stressed in the sources, is to identify and then reverse the specific causative factors for that particular non-union. You have to figure out why it didn't heal and address that root cause.
Tailor the treatment to the cause.
Precisely. If the primary problem is mechanical instability, like in a hypertrophic non-union, the focus needs to be on providing stable fixation. If the main issue is a biological deficiency, like poor blood supply, a large gap, or lack of cellular activity, like in an atrophic non-union, then you need bone grafting or other biological stimulation. And if infection is present, that must be eradicated first and foremost before definitive bone healing can occur.
So fix the root cause. What are the different treatment options actually available? Can non-unions be treated without surgery?
Treatment can be non-operative, although this is generally less common or successful for well-established non-unions, especially atrophic ones. Non-operative options might include functional cast bracing, which uses controlled forces and allows some function, potentially stimulating healing in certain situations, mainly stable hypertrophic non-unions of long bones like the tibia, or electric or electromagnetic stimulation.
Which we talked about earlier.
Yes, which we discussed can potentially help convert fibrous tissue into bone, particularly useful as an adjunct or sometimes primary treatment for certain types of non-union, though success rates vary. Non-operative methods are generally best considered for delayed unions rather than true non-unions, especially those with minimal gap and manageable motion. They often can't correct significant deformity like shortening or malalignment, and they may require very prolonged immobilization, which has its own downsides.
So surgery seems more common for true established non-unions.
Yes, operative treatment is frequently required for established non-unions to achieve reliable healing. The surgical goals typically involve several components, often combined.
What are the main goals of surgery?
First, achieving proper alignment and reduction of the fracture fragments. Second, stimulating the biology, usually through bone grafting to bridge any gaps, provide osteoconductive scaffold, osteoinductive signals, and sometimes osteogenic cells. The type of graft used: autografts, allograft, substitute, sometimes even vascularized grafts, where bone is transferred with its own artery and vein for very large defects, depends on the situation.
Okay, alignment and grafting. What else?
Third, correcting any underlying biomechanical problems that might be stressing the non-union site, for instance, performing an osteotomy to change the bone's alignment and improve load distribution. Fourth, and absolutely critical, providing stable fixation to eliminate detrimental motion at the non-union site.
What kind of fixation is typically used in surgery for a non-union? Is it different from fixing a fresh fracture?
It often involves the same types of implants, plates and screws, IM nails, external fixators. But the emphasis is usually on achieving very rigid or very stable fixation, especially for atrophic non-unions that lack intrinsic biological potential to heal quickly. You need to give the biology the best possible mechanical environment. Sometimes revision of previous fixation is necessary if it failed or wasn't adequate.
What about infected non-unions? That sounds incredibly complex.
It is one of the most challenging problems in orthopedics. Management is complex and almost always requires a staged approach. The first priority is eradicating the infection. This typically involves aggressive surgical removal of all infected soft tissue, dead bone, sequestrectomy, and often the infected implant itself, debridement.
Clean everything out first.
Everything. This is often followed by a period of systemic antibiotics and sometimes local antibiotics delivered via antibiotic-impregnated beads or cement spacers placed in the defect. Only once the infection is demonstrably controlled, which might take weeks or months and multiple surgeries.
Then you can think about fixing the bone.
Exactly. Only then can the second stage proceed, which involves addressing the bone defect, usually with bone grafting, and providing stable fixation. Methods like the Ilizarov external fixator are particularly useful here because they can provide rigid stability, manage infection in soft tissues, and even allow for bone transport, gradually growing new bone to fill large gaps all at the same time. But it's a long and arduous process for the patient.
You mentioned techniques earlier like shingling or decortication. What are those and when are they used?
These are surgical techniques specifically aimed at stimulating the local biology, particularly useful in atrophic non-unions, where the bone ends seem biologically inactive or quiet. Shingling, or sometimes called pedaling, involves carefully elevating thin flaps of the outer layer of bone, the periosteum, along with small slivers of the underlying cortex, all around the non-union site, while preserving their soft tissue attachments.
What does that do?
It essentially disrupts the relatively avascular scar tissue and sclerotic bone ends, causes bleeding, and exposes the underlying cancellous bone and marrow elements. This stimulates an inflammatory response and releases growth factors locally, encouraging new blood vessel formation and recruitment of bone-forming cells from the healthier periosteum nearby. It's about trying to wake up the bone ends biologically and kickstart the healing cascade that failed initially. Decortication is a similar concept.
So, trying to create a better biological environment right at the site. What about very complex or severe cases, say a non-union involving a joint?
For non-unions that involve or are very close to joints, metaphyseal, articular non-unions, the goal is not only to get the bone to heal, but also to restore the joint surface congruity and alignment as accurately as possible to preserve joint function and prevent arthritis. This often requires meticulous reduction and fixation, possibly with bone grafting.
And for those long-standing pseudoarthroses, the false joints.
For very mature pseudoarthroses, surgery often involves completely excising the fibrous tissue and the synovial-like lining of the false joint, freshening up the sclerotic bone ends to expose bleeding bone, and then proceeding with stable fixation and bone grafting.
Are there situations where fixing it just isn't feasible?
Unfortunately, yes. In some older patients with very severe long-standing non-unions, perhaps with poor bone quality, multiple failed surgeries, or significant soft tissue problems, prosthetic joint replacement might be considered as a salvage procedure to restore function, essentially bypassing the non-union. And sadly, in very rare cases where the anticipated functional outcome from extensive reconstruction is extremely poor, or the risks of surgery are deemed too high, like uncontrollable infection or massive bone loss, amputation might become the necessary last resort, though this is always considered very carefully. It's really clear, isn't it, that treating non-unions successfully requires a deep understanding of both the specific biological reasons why healing failed in that patient and the complex biomechanical forces at play. Then you have to choose exactly the right strategy or combination of strategies to correct those specific issues. It's highly individualized.
Absolutely. Our deep dive today, really starting from the incredible material science of bone itself, moving through the body's intricate step-by-step healing dance, and then exploring the complex world of surgical interventions, implants, and their potential failures. It just underscores how tightly interconnected the mechanics, the biology, and the materials science truly are. Understanding all these layers, the biology, the mechanics, the materials, seems absolutely essential for anyone involved in trying to tackle the tough challenges of bone injury, especially those really stubborn non-unions.
It definitely highlights that fixing a broken bone isn't just about, mechanically putting the pieces back together. It's about creating the right environment, both mechanically stable and biologically supportive for the body's own amazing healing machinery to actually succeed.
Indeed. And it kind of leaves you with this thought, doesn't it? Given how powerfully mechanical forces and precise cellular signals drive bone healing and adaptation, how might future treatments go even further beyond our current implants and grafts? Could we be heading towards therapies that use, say, smart biomaterials, materials that not only provide structure but also actively sense the local environment and release the exact biological signals needed, maybe even customized to a specific non-union's biological deficit,
Right.
really mimicking and actively boosting nature's own process to heal even the most complex breaks?
That combination of advanced engineering, maybe even bioresponsive materials, coupled with highly targeted biological cues, yeah, that feels like the real frontier in tackling these difficult healing problems.